So let me introduce Dr. Mariko Yabe. She is assistant attending in the hematopathology division. I think it's going to be a tale of two cities, and it should be very interesting. Come
on. Thank you very much for the introduction. Good afternoon, everybody. Today I'm going to talk about the case of 66-year-old man who presented with multiple neurologic symptoms, including memory loss, gait disturbance, and urinary incontinence. And I'm going to show radiology photos later, but the patient presented extensive dura-based disease, and also he had intraorbital masses. Also, he had multiple lesions, including renal, paraspinal masses, and multiple lytic bone lesions. And in addition, he also presented mild anemia and monocytosis. So his white blood cell count was over 7,000, and actually 30% of them were monocyte, and hemoglobin was around 9 grams per deciliter. So the biopsy of this presacral mass was performed, and also bone marrow biopsy was performed for the evaluation of anemia and monocytosis. So this is the brain MRI. We can see this like extensive multiple supratentorial mass, like thickness of dura. And also the PET showed right orbital mass. And also our PET highlighted this left renal and para-aortic regions. And bone scan also showed like multiple symmetric uptake around knee lesions and also distal tibia. And these lesions also showed uptake by PET scan. So the biopsy was actually done from this site. And this is the low power picture of biopsy. So biopsy showed soft tissue diffusely involved by histiocytes, and with higher magnification, these histiocytes has very round, plump nuclei with very foamy cytoplasm. So we saw proliferation of foamy histiocytes. And these histiocytes were highlighted by CD68, CD163. These are histiocytic markers. And these histiocytes do not express CD1A and S100. This is a summary of immunohistochemistry. So histiocytic infiltrate expressed CD68, 163, and lysozyme, but did not express S100, CD1A. And we also performed a couple of keratin or melanocytic markers, but these were also negative. And bug stain with AFB5 GMS are also negative, so we rendered the diagnosis of Erdheim-Chester disease. And this is a bone marrow biopsy of this patient. He is in 60s, late 60s, so cellularity is higher for his age. And under the higher magnification, we saw dysplastic megakaryocytes, small, and these separated nuclear lobes. So this is dysplastic megakaryocytes. And also, we saw the areas with diffuse infiltrate of immature monocyte. So in conjunction with monocytosis, this case was diagnosed with chronic myelomonocytic leukemia. So today, I would like to briefly talk about what is Erdheim-Chester disease, what is chronic myelomonocytic leukemia, CMML, and these just happened coincidentally, or are they related? So these three I'm going to briefly talk about. The first, so what is Erdheim-Chester disease? So this is a clonal proliferation of mature histiocyte. This is histiocytic neoplasm. And mean patient age at the diagnosis is usually in the late 50s, but like this patient. But rare pediatric cases have also been reported. And any organ can be involved. And actually, skeletal involvement is seen virtually in all cases. And like this patient, retroperitoneal involvement or CNS intraorbital lesion were often reported. And by literature, cardiovascular involvement is reported approximately half of the patients, but it is thought that this is likely underdiagnosed. And clinical course is actually very variable. Some patients show asymptomatic, and then some patients show very aggressive courses. And there is another kind of famous histiocytosis, which is Langerhans histiocytosis. And I briefly would like to compare these two. So Langerhans histiocytosis, aka eosinophilic granuloma. So we see a lot of eosinophils in the background, and these histiocytic infiltrates show like these oval grooved nuclei, coffee bean-shaped cells with sometimes have like eosinophilic cytoplasm. And also, so compared to this, Edham-Chester usually often show like foamy xanthomatous histiocytic morphology like this patient had, but can also show variable morphology. And immunohistochemistry is different. These both are highlighted by histiocytic markers, but LCH usually LCH express CD1A, Langerin, and S100, and in contrast, ECD does not express these immunohistochemical markers, so immunophenotype is different. But recently, molecular profile is now is revealed, and they both have same recurrent mutations which activate MAPK signaling. The most famous one, most often seen one is BRAF V600E mutation. And actually, because the molecular is the same and maybe molecular pathogenesis is the same, so there are cases that the patient has LCH in one locus and ECD in another locus. For example, this is the case that the patient had both lesions in one histologic section. So this is a 55-year-old woman who presented with splenomegaly. And on the section, there is these like eosinophilic histiocytic infiltrate, and also we see these xanthomatous histiocytic infiltrate. And this case showed BRAF V600E mutation, and interestingly, this had distinct different immunophenotypes. So this pink-looking LCH area expressed 1A, S100, and CD163. This is histiocytic markers. And these xanthomatous infiltrates were negative for CD1A and S100. So we sometimes experience these kind of cases. And then what is CMML? So CMML is a myeloid malignancy which shows both feature of myeloproliferative and myelodysplastic features. So that is proliferating and also dysplastic morphology. And median patient age is late 50s or early 70s, like our patient. And we have diagnostic criteria. So the patient show persistent peripheral blood monocytosis, which is defined as more than 1,000 per microliter. And also we see dysplasia at least in one lineage, like megakaryocytic lineage, myeloid lineage, or erythroid lineage. And this case, our case, presented with this megakaryopoiesis. And also, to diagnose as CMML, we have to exclude other disease like chronic myeloid leukemia with BCR-labeled translocation or other myeloproliferative neoplasm like fibrosis with JAK2 mutation. We have to exclude those diseases. And recently, of course, now we have so advanced molecular genetic tests, and CMML are reported to be associated with somatic mutations of these TET2, SRSF2, SXL1, RANKS1, and RAS mutations. And these are the percentage reported association with CMML. And actually, virtually all cases of CMML has at least one of these mutations. And also this case, this disease prognosis is very variable. Some indolent one, two very aggressive one showing transformation to AMML. Then, in our case, are these related or just coincidence? Interestingly, high prevalence of myeloid neoplasm has been reported in association with histiocytosis. So the first paper, this case includes more than 100 cases of histiocytosis, like ECD, LCH, and a lot of cases are actually from our Memorial Sloan Kettering cases, and quite a few number of cases, like 10% of patients of histiocytosis had a concomitant myeloid neoplasm, like myeloproliferative neoplasm or MDS. And then also myeloid progenitor cells in the bone marrow of these cases are also reported to harbor a BRAF mutation. This means, for example, the cases that patient has Erdheim-Chester disease elsewhere with BRAF mutation, and patient has concomitant myeloid neoplasm. For example, primary myelofibrosis and JAK2 mutation was identified. But also this myelofibrosis has BRAF V600E mutation. So from these findings, support that actually hematopoietic progenitor cells are a cell of origin of histiocytosis. And going back to our case, so our case, presacral biopsy was diagnosed with ECD, bone marrow was diagnosed with CMML. Actually, we found the same NRAS mutation in these cases. And just I explained, LCH and ECD, they have activating signaling of MAPK, activating MAPK signaling. NRAS is one of them. And CMML, also 11% of cases have NRAS mutation. So the case actually had same NRAS mutation, one in here, another in here. Then our interest is histiocytosis diagnosed by tissue biopsy can have myeloid neoplasm-related mutation, like JAK2 mutation, TET2 mutation. And actually, this has not been studied. So this means, for example, this one, ECD in bone biopsy has BRAF mutation. Bone marrow has JAK2 and BRAF. Then, does this have JAK2? This was our question. So we studied with our cases. So I'm going to briefly talk about results. So we found 4 cases that tissue biopsy of histiocytosis was done and bone marrow biopsy was also done. And same mutation were identified in histiocytosis in tissue biopsy as well as bone marrow biopsy. For example, this case 6, this is our case that I just presented. ECD in kidney, presacral mass, and CMML in bone marrow share same NRAS mutation. And for example, the first case, histiocytic sarcoma in spleen and acute myeloid leukemia in bone marrow share same TP53 mutation. And also, we found 5 cases of tissue biopsy without corresponding bone marrow biopsy. And these tissue biopsy had myeloid neoplasm-related mutations. I'm going to pick up 2 cases, and I will show you pictures after this. But we just submitted the abstract for upcoming US CAP with this project. So the first case, for example, this one is 68-year-old man with lung biopsy, which was diagnosed with Langerhans histiocytosis. And this case have BRAF V600E mutation, but on top of that, patient had these 2 myeloid neoplasm-related mutations in high VAF. And there is another case that this is a 43-year-old woman who presented with multi-system ECD involving bone, skin, lungs. And this is skin biopsy, which was found with KRF5B ARC fusion. And ARC fusion is actually reported in ECD cases. And this case, on top of ARC fusion, DNMT3A, which is often seen in myeloid neoplasm, has been detected with a very allele frequency of 33%. So our conclusion and take-home message is high prevalence of myeloid neoplasm has been reported in histiocytosis. And actually, our study also confirmed that quite a few cases of histiocytosis have concomitant myeloid neoplasm. And we also identified that tissue biopsy of histiocytic neoplasm have myeloid neoplasm-related mutations. And these findings give another support for hematopoietic stem cell as origin of histiocytosis. And so if you see histiocytosis and if patient present with abnormal CBC or if not, please do not forget to evaluate bone marrow. Maybe patient has concomitant myeloid neoplasm in the bone marrow. So this is the last slide. Thank you very much for your attention.
Was the patient with the lung LCH a cigarette smoker?
I have to go back
That
to
disease is largely driven by
yes.
abnormal immune reaction to antigens in cigarette smoke.
I have to look for it. I'll do that. Yes.
I don't think it had the morphology of typical morphology of the lung in that case. Am I right? It had more aggressive looking histology, which is, you know, more typical LCH morphology than the more kind of indolent appearance of the. So I think is there evidence that it's systemic? Do you know that?
The patient is not systemic actually.
Just lung, yes.
Oh, actually, it is it was not multifocal, so I have to look for the history of cigarette. But morphologically, it looked like, you know.
I'd be interested to look at that with you. Just
Yes, I'll pick up the yes.
Because it, you know, it's an interesting point. If you're talking about a stem cell process, we still don't know why these cigarette smokers, some of them get the pulmonary LCH. Maybe they all have stem cell.
Yeah, I'll check. But as far as I understood, this patient has single lesion in lung. But I'll check.
Do we have sequencing results from more run-of-the-mill pulmonary histiocytosis? I guess we haven't done that.
The lung case?
No, the more comprehensive sequencing results in the lung histiocytosis.
No, some cases, actually the molecular variation has heterogeneous, like, some are done with, for example, like digital PCR, some were done with impact, some are done by fragment analysis, so it's kind of, yeah.
So I have a question.
Yes.
So the ECD patients respond really well to targeted therapy.
Yes.
So when they have, for example, this patient, do you expect?
What I heard, I don't know the science background, but what I heard, I was chatting with one of the clinicians of neuro-oncologist, and he often experienced once he gives, MEK inhibitor or those like targeted therapy for ECD, actually bone marrow shows progression. That's what he has as an impression, but I don't understand the background science, but that's what the clinician have an impression. That's what I heard. Yes.
My second question is that some of them obviously have impact, right?
Yes. Yes.
So do they have also clonal hematopoiesis? I know it's hard.
Yes. Actually, that's a good point. Yes.
Your TET2 and
yes. Like yes.
Clonal hematopoiesis.
Yes. So actually, that's a very important point. So now we started also doing a sequence of the peripheral blood to see if the patient has CHIP, coronal hematopoiesis. But usually, as far as I read by literature, coronal hematopoiesis for like DNMT3, TET2, from like 5%-ish to 15, so 15%. So I think if we see like 30-something% in that skin biopsy with kind of minimal like contamination of peripheral blood, I believe that is real. But now we decided to kind of screen with peripheral blood molecular analysis. Yes.
I'm sure they're circulating.
Yeah. Yes.
But still, I think the ratio is too high.
Yeah,
Ratio
the
is
ratio is
high.
high. Yes.
But I was thinking whether these patients really have also higher level of circulating
Yes.
markers, which part of the clonal hematopoiesis.
Yeah. Thank you so much.
Thank you.